what people asked me to talk about was continuing the fetal theme, I think, rhythm disturbances. So it's a little bit dry, the topic, like rhythms generally. Mike's not on the call, so I don't think he'll listen to that. But I can talk you through what we see and how we deal with it. Hopefully everybody can see, as we say. So we know that on the whole, rhythm disturbances, so everybody, a mum or anybody, midwife, anybody likes to hear a nice regular heartbeat when they're assessing the fetus in a pregnancy. And we know that in somewhere between 1 in 100 and 1 in 50 pregnancies, you get irregularity, and that causes a great deal of alarm. Usually it's absolutely no consequence at all, but as I say, it does create alarm. The two sort of, if you like, regions where you begin to worry is if it's excessively slow. So that's defined as being less than 100 or excessively fast, so anything over 180. So if you use those two sort of criteria, a normal fetus can have a heart rate anywhere between 100 and 180 and be completely well. So that's the kind of range that we give people not to worry about. Everybody assumes it should be 140, but I say there is a wide range of what's acceptable. In an ideal world, we would do a fetal ECG, same as we do for a baby postnatally, to assess what the rhythm is, but that's clearly not practical. People have tried over the years to stick electrodes and things on mum's abdomen and try and pick up the fetal cardiac rhythm doing ECGs, and people have actually produced books, as you can see there, that you can buy on the dreaded Amazon and places. But on the whole, you get too much interference from the mum's subcutaneous fat, muscle tissue, etc., to allow an acceptable trace. You can get a basic heart rate and a sort of well-being thing, just a flick, if you like, showing that the heart rate is and the baby's heart is active and present. But that's no different to what you get on a scalp electrode during labour when they put it on, or a CCG when they actually just monitor baby's movements and fetal heart rate by putting a belt across mum's tum if they're concerned. There is a more technical, which is really research side of things, never really caught on, magnetography, as you say, because all electrical activities create magnetic fields. So don't ask me anything about this, the physics of this behind it all, but effectively you can pick up those magnetic fields, use computers to process it, and you can produce the kind of thing we've seen on the right side of the screen there, an ECG like you'd get on a monitor or wherever else. However, recordings take about an hour to 2, and that's how you do it. So it's not really practical on a day-to-day basis. So never really caught on, apart from as a research side of things. No mum's going to lie still for that length of time with that thing stuck to her abdomen. So effectively what we rely on is our basic ultrasound. As you know, any lady being pregnant, they get a very early scan around about 12 weeks, just looking at the baby, the thickness of the baby's neck, fluid collections around the neck of baby. Increased fluid is indicative of potential chromosome problems or complex congenital heart disease. There's also the 20-week scans where they look at all the structures of things, but in the same way as you can use ultrasound for picking up structural abnormalities, so you can use Doppler and M-mode, so I will talk a little bit more about those in a minute, to actually try and analyse what the rhythm and the rates are doing. Doppler is literally sticking your probe. You can use pulse Doppler, so by lining up with a particular section of the heart on pulse Doppler, you can pinpoint an exact area you want to monitor the velocity of the heart, the velocity of the blood at that particular point. And the gate, the area that you pinpoint it with is called the gate on the ultrasound cursor, and you can widen that gate or make it smaller on the machines. So they allow you to pinpoint various areas. So you can Doppler using initially structural type imaging, the picture we've shown there on the right. You can put your gate over a particular area, the aortic valve, the pulmonary valve, mitral valve, whatever you want to do, or by opening up the gate and getting certain views, you can Doppler pick up the blood velocity, the speed of the blood in side-by-side vessels. So you can actually Doppler aorta and SVC. You can do mitral inflow and aortic outflows by looking at those things, and that allows you to pick up, if we can see the pictures on the right there, you can get, say, for the aorta, you can get an aortic velocity. and you can get a little SVC velocity. So you know that the SVC is basically atrial, aortic is ventricular contractions, so you can work out AV relationships using that. Similarly, mitral inflow, aortic outflow, you can pick up again similar sorts of pictures as we've shown there, corresponding, as we say, that's what we've already said about that one, the aorta and the SVC. Mitral inflow, you pick up again, as I say, on the normal ultrasound, you show mitral valve inflow. You can pick up on a 5-chamber view, the aortic coming out, so you can go from LA to LV to aorta. And by putting your Doppler, opening up the gate, to making it quite wide, you can pick up blood flowing through the mitral valve and going out through the aorta to produce a sort of mitral inflow pattern and an aortic outflow pattern. You assume mitral inflow corresponds to aortic contractions, aortic outflow corresponds to ventricular contractions. So by looking at the patterns, you can go from mitral to aorta and roughly work out AV timings, if you like, or at least show that there is AV consistency. I'll talk a little bit about anti-Rho, anti-LAR and whether that's useful to predict later, but that's one way we can try and do it. What we tend to do more routinely is using M mode. So when I first started work, we couldn't actually see structure. The first echo machines were all just M mode, which is basically firing an ultrasound beam down a line. Everything it hits gets reflected back. Solid things get built up by the computer as being white. Liquid things get built up as being black. So initially, all you could see was black and white, like the pattern at the bottom. Now what we can do, we can use 2D real-time imaging. So if we look at the picture here, this is obviously a fetal chest. You've got a little 4-chambery view there. You can aim your cursor line down to come through the atria, through the middle of the heart, and then through the ventricle. Down on the M mode, everything it hits gets reflected back and produces an M mode image. So all the going through the lungs and the skin produces the white bit at the top. As it goes through the atria, liquid, you get that bit. Where the atrial wall contracts with the eye of faith, you can just see little blips. So, you know, those are atrial contractions. Where it goes through the middle of the heart, you get typically that pattern. Where it hits the back wall of the ventricle, you get little bumps at the bottom. So that's, you know, those are the ventricles. So you can do atria to ventricular contraction, atria to ventricular contraction, atria to ventricular contraction. So it will show you one-to-one conduction. And we tend to use that M mode approach for trying to work out most of the rhythms. So the commonest irregularity we see, which creates an enormous amount of angst, and we used to spend hours and hours trying to analyse these because they all used to get referred in as a cardiac rhythm disturbance, are simple atrial ectopics. So we all get, obviously our normal impulse coming through, starting at the top of the heart, comes from the SA node, passing down to the AV node. We all have the potential to produce ectopics from other sites in your atria. So 5 cigars and 4 cups of black coffee, and we all start producing ectopics from all over the place up in our atria. They will be created through, they will connect into the normal conduction tissue, and some will be transmitted through, some won't. But effectively, if you've just had an electrical impulse leave your SA node and you produce an atrial ectopic next to it, you've got 2 traveling down the electrical pathway too close together. So they may both produce conductions, but then the SA node will reset. So instead of being and have a longer delay, so instead of having a nice regular heart rate, you get marked irregularity. As I say, when the midwives and people listen in, they like to hear nice regular tom-tom beats along the way. If they're all over the place, then it creates panic. But most of these are just atrial ectopics that we all get and are of no great significance. If the structure of the heart appears normal, you can just reassure and tell them not to go away, not to worry about it. And what we would normally say is, provided the heart rate is between 100 and 180 beats per minute, ignore irregularity along the way. Just get on with it, because the baby doesn't care whether it's 140 beats regular or 140 beats irregular in a minute. We know that if you're doing lots and lots of ectopic beats, about 1 in 200 babies can go on to develop true SVT, so it can be a precursor along the way. But if I show you the kind of pattern we're doing, if we go back to the M mode cursor going through, you're going through the atria to begin with, coming down into LA and picking up the ventricle right at the bottom here. So these are atrial contractions, the bits corresponding to what we're seeing there. So you get atrial contraction, middle of the heart again is that bit, back wall of the ventricle down here is this bit. So again, you've got atria to ventricle, atria to ventricle, atria, don't see it coming through. And then if you look, you've got an early little beat here, an early little dimple. That's an extra premature atrial ectopic. In this case, it looks like it is conducting down to there. So there's something else coming through. But instead of being nice and regular, you've got that resetting because we've got irregularity going on down here. So premature atrial ectopics, as we say, of no great significance. Ventricular ectopics, again, same principle. You'll see extra bumps down in the ventricles, but nothing in the atria. So it's the same principle, much less common. Again, we all get ventricular ectopics all the time. Most of the time, irregularities will be labelled as premature atrial ectopics. Probably doesn't matter, mostly benign. Clearly, it's sensible that you may get runs of VT. So if we're getting like 200 beats per minute, there's something going on. And if there's loads and loads of ventricular ectopics going on, it's always worth looking for structural things, particularly things like tumours sitting in the heart that can create, as you say, multiple ventricular ectopic beats. So atrial ectopics very common, ventricular ectopics much less common. We've already sort of kind of talked about this to a degree. You can work out are they conducted or not. So these are premature atrial complexes, premature atrial extrasystoles. You can show, do they conduct through and does it reset? So we showed that earlier along the way. You can see A to V, etc. And then a premature one not being conducted and then resets itself back to there. So useful to try and work out what we're doing. But as we say, most of the time, it's just a question of reassuring and sending them on their way. We don't even bother to see these anymore. Most of these just dealt with out in the district generals now rather than referred in for the fetal clinics, unless they're extreme. Block just means not conducting as compared to conducting. So as we say, not a great deal. Really, commonest thing we see, 8 to 9 out of 10 irregularities are these. So these aren't really classified as rhythm disturbances. If we look at fetal tachycardias, so fast heart rates, this is over 180. So clearly if a baby's in distress, it produces sinus tachycardia like any of us, indication for baby in trouble along the way. If mum's got a high temperature, so ruptured membranes and she's got infection in there, chorioamnionitis, the baby will still have a temperature, baby's heart rate will be going fast. So if you kind of ruled out those kind of things, then it's exactly the same rhythm disturbances we see in postnatal life as in antenatal life. So we'll talk about them, the SVTs, the re-entry tachycardias. People make rhythms very complex. I can say this again because Mike's not here, but basically they either come from the atria or the ventricles is the easy way to look at it. And supraventricular tachycardia is the good old-fashioned SVT. People call this, the other name for them is AV re-entry tachycardias, atrial tachycardias. They all basically mean the same sort of thing. Ventricular coming from the bottom. So the different types, but people classification can make it complex and it doesn't need to be as complicated as it is. So we know that in childhood and same for antenatal, because I say they're exactly the same sort of rhythm disturbances. 19 out of 20 episodes of SVT use a re-entry circuit. So they will have an accessory pathway. The one that we all know about is the Wolff-Parkinson-White pathway, but there are quite a few being marked over the years and classified over the years. So when Mike and people go try to do their ablation therapy, they're going looking for these accessory pathways. The re-entry circuit involves the AV node. So you've got your SA node coming down to your AV node, His bundles going down to your ventricles. So the circuit involves the AV node and the accessory pathway, creating a short circuit through there, spinning round. Again, people talk about orthodromic and antidromic, which confused me for years. It depends which way it's going. Antidromic means it's going anti-clockwise. Orthodromic means it's going clockwise. It's as simple as that, but it's using the AV node, the accessory pathway, to cause a re-entry circuit. Antidromic, backwards, will cause, anti-clockwise, will cause wide QRSs, will look like VT. Orthodromic, going clockwise, will cause narrow QRS complexes. That's probably the most common one we see, the narrow complex SVT that you see postnatally. Is it sustained? So if we see a baby with a heart rate of 200, 220 a minute, we want to know, is it one-to-one conduction? Is it happening all the time? How's the baby? So again, using the same thing we see before, you can put your cursor through the atria and the ventricles, and you can pick up atrial bumps and you can pick up ventricular bumps. And you can show not only the rate, but you can show each atrial bump produces a ventricular bump. Each atrial bump produces a ventricular bump. So you've got one-to-one conduction, heart rate 240 in this example. It's most likely one of these. Can't tell which way it's going because you obviously can't see the QRSs, but most likely it's orthodromic, going, as we say, in the clockwise direction. And it's exactly the same set of drugs that we would use for a baby postnatally along the way, written down there. We'll talk a little bit more about them in a minute as we go through. Same thing again, as you say, atria to ventricles. You can pick up your atrial bumps, your ventricular bumps, and you can determine one-to-one conduction and the heart rate. So really anything over about 180, 200 beats per minute ain't normal. And that's also true of neonates. So a neonate really screaming its head off might get to 210, 220 beats per minute. So anything 240 beats per minute is probably going to be an abnormal rhythm. And then it's a question of trying to sort out which it is. So main complication is obviously hydrops, so heart failure in utero. Babies, if they've got a structurally normal heart, haven't had a lifetime of abuse, so they've not had cigarette smoking, vodka, all the rest of it that we're all subjected to when we get older. So they will tolerate SVT 240 for quite a few days before they start to develop evidence of cardiac compromise. And that's true also of younger children, often 24, 48 hours. So the ones that come in with severely impaired LV function and cardiac failure have probably been going for quite a long time. Hydrops is basically exactly the same fluid buildup. You get an elderly granny or anybody else along the way. So we get pleural effusions, you get ascites, and you get a boggy baby if they come out too early. So multiple causes of hydrops, but persistent tachycardia, and it has to be persistent, is one of the recognized causes. So it's working out, as you say, and trying to avoid this. So when we first see the ladies, they're referred across, you want to know, is it happening all the time? Because if the baby's in and out of it, it probably will not progress to hydrops even if we do nothing. You want to know how fast it is along the way, because obviously the faster, the harder the heart's working, the more likely it is to wear out along the way. Is there any evidence of hydrops initially, or is the baby's cardiac function excellent along the way? So standard policy tends to be, if there's no evidence of cardiac compromise at all, we still rely on good old-fashioned digoxin. So what you're using the drugs for is to break that re-entry circuit. So they either work on the AV node, on the accessory pathway, or they work at both sites. So digoxin classically works at the AV node, slows down conduction through there. Flecainide will work on the accessory pathway. Amiodarone will work in both sites. So non-hydropic baby, we tend to give them digoxin along the way. We have to be careful, and I'll put it on a slide later, that mum. So if you think an elderly granny coming in with heart failure will get digoxin dose of about 62.5 micrograms to 125 micrograms a day. We give these ladies 1,000 micrograms a day because the placenta is great at blocking out or limiting what can get through. So to get through a reasonable dose to the baby by treating mum, we have to give whacking great doses. So you have to be careful that you're not poisoning mum. Same true of flecainide. So we give mums big doses of flecainide along the way. Amiodarone we use occasionally, but again, usually if you use it for any length of time, most of you will be aware that amiodarone creates hypothyroidism, low thyroid. So if babies in the utero are on it for any length of time, they come out with virtually no thyroid activity at all. So you might have controlled the heart rate, but you've given them, they will need a lifetime of thyroxine replacement. But it's the same armament treatment that we use postnatally. Usually we give it to the mum. There's debate about, do you need to admit the mums? Should you give it orally? Should you give it IV? We tend to use oral stuff as an outpatient token, but you would not expect miracles to work for at least 4 or 5 days. And the treat, like a bit like postnatally, is not to think, well, digoxin doesn't work, we'll switch straight to flecainide. Flecainide doesn't work, switch straight to amiodarone. You do have to sweat it out for several weeks of each drug to see where you're going. So usually if digoxin's not worked after 7 to 10 days, you might add flecainide. You give that then 2 or 3 weeks before you start upping the doses, obviously checking mum's levels along the way. Rarely we will get, so most of the fetal medicine consultants are now getting specialized in utero transfusions for the rhesus type diseases. along the way, so they can get access into the umbilical vessels, and we can, in theory, give fetal administration of adenosine, which will obviously work and be gone instantly, but you can also give these down the umbilical vein if we want to. Delivery becomes an option. So if we're worried about hydrops, or the hydrops is developing, you know that if you deliver at 28, 30 weeks gestation, the hydropic infant is going to die. Nothing you can do about it. If it's 35 weeks, 36 weeks, the question is, do you deliver the baby or do you give this a trial for a week or two, accepting that you may have in utero death? And that's always a hard one to try and work out what to do. Most of us would leave them inside, because there's no doubt that the womb is an excellent ICU type setting. But the further on you get, sometimes you may be better or prudent to deliver, which would obviously be cesarean, rather than keep plodding on treating mum. Flutter, unusual. We probably see 1 or 2 a year. So again, it's basically exactly what he talks about. Atrial flutter, multiple atrial electrical activity fluttering around in the atria, producing impulses through. So using the normal conduction tissue. If we put an atrial pacemaker into you and set it at 400 beats per minute, so most atrial rates are over 350. So if we paced your atria at 400 beats per minute, you would never, thankfully, transmit through at 400 beats per minute to the ventricles. Otherwise, you've got a VT of 400 beats per minute. Your AV node will block you out, and you might produce 2 to 1. So you'd have 200 beats per minute of VT, still not good. And it's the same for nature anyway. So if you have atrial flutter on the whole, for whatever rate, fast rate, you will usually get blocked down to the ventricles along the way, but it will still produce very fast ventricular rates. So if your atrial rate is 400, your ventricular rate may be 200, 2 to 1 blocked. Classically, it's a sustained rhythm. So instead of being intermittent, like somebody said, some of the SVTs come and go, this is usually constantly going. And it's usually more after in the 3rd trimester, the 3rd section of pregnancy. So later on along the way. Much more likely to produce hydrops than standard SVT. And again, harder to control. So postnatal baby and atrial flutter, we know that if we cardiovert them, give them a DC shock, you will get nearly all of them out of atrial flutter, and for the vast majority, it won't come back. So electrical cardioversion is an excellent treatment for postnatal atrial flutter. We obviously can't do that in utero, so we have to use drugs. But again, if you're picking up the atrial flutter at 37, 38 weeks, you may be better delivering the baby and shocking it rather than giving mum all these and seeing what happens for 2 weeks along the way. So again, it's a balance of what to do at that time along the way. But an unusual rhythm, but we'll probably see, as we say, 1 or 2 a year. Classically, again, you're relying on the end mode. Usually it looks obvious, because when you image them, you can see the atria going like a bat out of hell, and it just looks bizarre. But if you want to prove it, you put your cursor again through atria and ventricles. So in this case, we've gone the other way around, right ventricle on the top. So the first thing we hit is right ventricular wall. So these are the right ventricular blips showing contraction of the ventricles. Atria down the bottom here. These are atria. So atrial rate is about, as we said there, what have I put? 462. Ventricular rate, if you work it out, is 231. So we've got 2 to 1 block. But they will go this fast, anywhere between 350 and 500 beats per minute. Ridiculously fast. So as again, say, but fortunately ventricles don't follow, they always block out. But an interesting but unusual. Other weird and wonderful ones, atrial ectopic tachycardia is effectively an atrial focus. So instead of your SA node producing your electrical, you've got an ectopic focus which will produce ectopics, but it is constantly sending out ectopic beats. So instead of the occasional ectopic beat, an atrial ectopic tachycardia means there's an ectopic focus in the atria constantly sending out electricity, and it's more dominant than your SA node. So it may be 200 times per minute at atrial ectopic. The marker is that they are absolutely regular. There is no sort of diurnal variation at all. There's no daytime variation. So if you check it at 10 o'clock in the morning, it's usually 200 beats. 2 o'clock in the afternoon, it's 200 beats. 10 o'clock at night, it's 200 beats. It's constant all throughout the day is the marker for that. Europeans call JET, junctional ectopic tachycardia. The North Americans call it JET. So tachycardia originating from your junction, just beneath your AV node, the AV node region. So we see JET we call it jet, on the ICU post-surgery. So you get a focus there, your junctional region firing off again electricity, dissociated usually from the ventricles. So you will get a focus coming from there, usually again fast. The Americans call it junctional ectopic tachycardia. The Europeans call it persistent junctional reciprocating tachycardia. It's the same thing. Very difficult to recognize on antenatal scans, unfortunately very rare. So quite difficult to pick up postnatally as well. Most of these show a lot of resistance to treatment along the way. Sotalol is a drug we used to use quite a lot. We talked about having to make sure it's safe for mum. One of the side effects of, sotalol and amiodarone is that it could affect the mum's ECGs significantly. So you can end up creating quite marked prolonged QT prolongation on the mum's ECGs as a side effect of the drugs. And I said we're giving big doses. So you might treat the baby's rhythm, but you're then putting mum at risk. So we have to be careful with what we use. But again, these things can sometimes get you out of a hole if need be. Ventricular tachycardias, ridiculously rare, as we say along the way. Often with structural anomalies, we talked about tumours earlier. They're often an indication for the channelopathies, the kind of sudden death things that you hear about all the time with the poor old footballers recently, wasn't it? But those kind of things that we look for. And often VT antenatally will be mistaken for SVT. Flecainide, as I say, that we would use as a treatment for SVT, will also treat VT. So sometimes purely by chance, if we've misdiagnosed VT as SVT, we will help treat this with flecainide. So it's a similar sorts of treatment exists along the way, and it only becomes more evident afterwards. M mode can do it. So you again, if you look here, if you chop through your atria down to your ventricles, so your atrial contractions may be nice and regular, normal. Your ventricular contractions are completely out of sync with them, going much, much faster. So that would be an M mode analysis that shows VT, because your atria are 140 beats per minute, your ventricles are doing 290 or 230, whatever that rate is along the way. So you can prove it, but often quite difficult to prove it. Fetal bradycardias, so going the opposite end of the spectrum, going slow, can be just normal. So as we said, everybody likes to hear a baby's heart rate being nice and fast and nice and regular. And they get alarmed if it's 105, 106. But babies are unlikely to get into trouble unless they get significantly slower. So 106 may just be normal for some babies. But it's unnerving when you're scanning fetuses sometimes. The heart rate almost seems to slow down and stop. So a mum can get quite alarmed, usually just move off. But they do have quite excessive vagal tone. So in the same way as you can go from suddenly 140 to almost stand still for a few seconds, so you can have quite marked vagal tone that will produce a resting heart rate of say 106, 108 beats per minute through most of the pregnancies. Baby's well, active, cardiac function excellent, it's just normal for that baby. Can go with major structural things, so the really grotties of the world, the isomerics, where you have two left atria or two right atria, and usually complicated hearts. And if you've got isomerism, two left atria or two right atria, obviously sometimes that can involve the electrical conduction tissue. So congenitally corrected transpositions again involve the conduction tissue. So usually major structural problems can produce quite marked sinus bradycardia along the way. If mum's on these beta blockers or mum's hypothyroid, again you can see it. Cranial lesions in the brain for babies. So the baby's got really bad brain problems along the way, marked hydrocephalus or whatever. In the same way as the neurosurgical ward postnatally, if they've got brain tumours, will produce quite marked vagal tone and bradycardias. So you can see it antenatally. We had a lady once who'd had an RTA, had quite marked seatbelt injury all across her abdomen. She was pregnant and the baby had severe fetal bradycardia, about 70, 80 beats per minute. You proved it was not blocked because it was one-to-one conduction. For 2 weeks, the baby was okay, and then it just went back to normal. So presumably that was myocardial stunning or whatever you want to call it, and damage to the electrical conduction at that time. People have also reported that bradycardia, jumping from slow to fast heart rates, can be a marker of long QT syndrome antenatally. So if we see a baby who's 70 beats per minute, 1 minute, 180 the next minute, then it's dropping down to 80 again, then back to 180, can be normal, or postnatally we have to look for this. as we say, as a marker of long QT. Sinus bradycardia, excellent. So as I say, most of the babies tolerate it very well if they're structurally normal along the way. You need to be certain it is sinus bradycardia and not block. So we need to prove a one-to-one conduction with our M mode. So for every atrial beat you pick up, there's a corresponding ventricular beat. And as I say, occasionally sinus bradycardia can be associated with premature atrial ectopics. So what people think is actual sinus brady is actually just normal heart rate with quite marked atrial ectopics, creating long pauses along the way. But as I say, on the whole, you can be reassuring. If we move then into heart block, what we're interested in is complete dissociation of the atrial beats to the ventricles along the way. So again, if you do your M mode, so looking through the heart, so you line your little line up through the ventricles down to the atria. So you can pick up atrial, in this case, the atria at the bottom. So we've got all little atrial bumps down here, marked for your atria, but ventricles picking up the free wall of the ventricle at the top here are the bumps. So there is no corresponding A to V. If you look at that atria, if you say, well, that atria goes to that ventricle, this one then should be going up there, but it's not. They're out of sync. So we're showing complete dissociation between the atrial contractions and the ventricular contractions. So complete heart block along the way. Everybody has a backup pacemaker down in your ventricles. So if you actually transect your AV node or burn your AV node completely and destroy it, you have a ventricular pacemaker that will pick up so you don't die, but it goes at about a third the rate of the normal SA node pacemaker. So if we say if you completely block conduction from the atria to the ventricles, the ventricular pacemaker kicks in, usually with a rate of about 50 in a fetus. So very alarming when the babies are going slow. In the old days, these babies just used to get urgent emergency sections at whatever gestation, and the baby's heart rate would still be 50 when it came out. But you then added 27-week, 28-week gestation prematurity to the problems. Now people are getting much better at not trying to assess, is it heart block? And if it's heart block, sitting tight, because the worst thing we want to do is heart block and prematurity. If you go through, just a quick reminder of the old-fashioned causes of heart block. So first-degree heart block, just prolonged PR. Interval, slow conduction from SA node, but following the normal conduction tissue in the conduction pathway. Second degree, conduction going down slowly. Wencky-Back drops off every now and again if a beat doesn't get through. So some going through, but more slowly. Then say every third beat completely drops off, not conducted. Mobits, same sort of thing. Some of the ventricles just not going at all. So in Wencky-Back, you see progressive prolongation. Mobits, you see some going through, some not going through. Second degree, third degree, complete break in the pathway. So atria doing their thing, ventricles doing their things. Bit harder to sort out antenatally, as we say along the way, but useful. Not really, doesn't alter what we do. So again, lots of atrial, nice normal regular atrial rates, ventricular really slow, no pattern to it at all, so complete dissociation, so complete third degree heart block. Can be associated with mega structural things, as we talked about, and if it's structural and heart block, high chance of baby dying in utero. No point getting them out because they say they're going to die, probably die anyway. If it's structurally normal, 95% of cases are associated with maternal antibodies. So I don't know if you've heard of these Rho and LAR antibodies. They're classic markers in you and I for the connective tissue disorders, the systemic lupus, the Sjogren's, those sorts of things that we all vaguely remember from general medical days. So the mums can carry the markers in their blood, the antibodies, for years before they present with the connective tissue disorder. And we know that these antibodies can get through the placenta, and they seem to have a predisposition for aiming straight for the conduction tissue. So we don't know why. Some ladies will have high antibodies levels and they never get a problem. Other ladies can have low antibody levels and they get heart block. So we don't know along the way. But as you say, if it's going to happen, it typically happens between about 18 and 30 weeks along the way. So if we know mum's got the antibodies, then we tend to screen them. No point particularly us seeing them. The midwives can just check the heart rate. And if the heart rate's 130 beats per minute, you know all's well. If it drops off to be heart block, then again, it's monitoring it along the way. So babies will tolerate slow heart rates remarkably well. So the indications for pacing postnatally would be a heart rate consistently less than 50, one of the indications for pacing. In utero, they will tolerate it quite well because mums often help the heart rate, the heart function, because mum's obviously providing, again, nutrients and everything to the baby. Less than 10% of cases, isolated heart block. So structure normal, heart block, but no antibodies present. So pretty rare. And occasionally in this situation, people have seen it completely disappear and it's got better. But hydrox is the end stage we all worry about. So that's what we're monitoring for, again, along the way. Can you predict it? So we know that the dodgy time for a lady who's got antibodies, often if the mum's got antibodies, you can keep an eye on her. A lot of these ladies have no idea that they've got the predisposition for connective tissue disorders. And the first indication is the baby cropping up with a heart rate of 55 at 24 weeks gestation. Creates utter panic, as we say, along the way. We started to try and say, could we predict who was going to get it? So we started to try and look for ways of showing the mechanical PR interval. So on the postnatal ECG, PR interval is atrial to ventricular contraction time, coming through. So we thought, is it logical if a baby's got antibodies and it's attacking the conduction tissue? First of all, you'd see first-degree heart block. That would then progress to second-degree heart block before the wiring breaks completely. So if you could predict this brewing, could you stop it by trying to give medicines, steroids, dexamethasone, hydroxychloroquine, etc., that might progress it progressing? So in practice, we were trying to find ways of predicting a prolongation of the PR interval and steady prolongation of block developing. So we went through weeks of screening these ladies if they're known to have antibodies, trying to predict atria to ventricular, so picking up your M mode pattern, your aortic outflow pattern, and showing that from the beginning of mitral contraction to aortic contraction, that equals the PR interval. If you saw that time interval getting longer and longer, could you load mum with steroids and prevent it progressing to complete heart block? So we spent a year or two doing all these studies. Effectively, you can't. So we didn't show any great reason to any ways of preventing it, really. Some people believe giving steroids and hydroxychloroquine to all the ladies known to have antibodies. So if you've had a pregnancy once with heart block and next time you get pregnant again, giving steroids and hydroxychloroquine, would you help prevent heart block developing next time round? There aren't enough numbers is the problem to get strength to prove these things. So most of these cases are just anecdotal that people give it. A lot of the obstetric people do now give it, but we know that fairly high dose steroids are very good at shutting off placental flow. So you might give the baby, get enough steroids into the baby that you think you're doing good, but the baby then doesn't grow because you're not getting any placental flow. So you produce one problem by trying to prevent another problem. So the verdict's still out. We know that delivering the babies, even if they've got heart block early, is a disaster. So as we say, realistically, you need to be about 2 kilograms to be able to surgically put a pacemaker in the neonatal period. So there's no point delivering a 1.3 kilogram baby because the surgical folks can't help. You can't transvenously pace them. Yes, you can give isoprenaline, that sort of thing along the way, but you're not going to get them, keep them going on that for 4 or 5 weeks to get them to grow. So leaving them in utero and trying to get them to grow in utero is probably the safest bet, and sweating it out. So the recent baby that we looked after at St Mary's, I think the heart rate was anywhere between about 45 and 52 beats per minute from about 20 weeks through to 37 when the lady got sectioned. And every week you kind of think the baby's going to be dead when she comes, but it didn't. It just kept plodding along at that sort of rate. So it is a question of sitting it out and trying to just sweat it out to get the baby big enough for a postnatal pacemaker along the way. So as we say, conclusion, topics very, very common, really only require reassurance, don't really need fetal cardiology to assess them. True rhythm problems, much less common, relatively rare. We probably see regionally, I guess, 10 fetal cases of SVT a year, something like that between all of us, 6 to 10, I would say. Atrial flutter, as we say, even rarer along the way. We still rely largely on M mode, despite people trying to do good fetal ECGs. And at one stage, people even went through trying to, could you externally pace babies and things, so of no great value. On the whole, carry reasonable prognosis, with or without medication. So bit like postnatal management of rhythm problems, it's often the antiarrhythmics that do as much harm as the rhythm disturbances. So people give them too fast, don't wait for them to react, don't wait for the time, because you want to be doing something. We have to be careful, A, not to create problems for the baby by over-treating them, B, not to create problems for the mums. Heart block, occasionally, if the baby's really getting into trouble and the baby's too small to deliver, we can admit the mothers and we can give them beta sympathomimetics, so the salbutamol type therapies, really high doses again. So you have to get the mums shaking, and the mums get a foul tachycardia, they get a really fast tachycardia. But by getting mum's heart rate up, you can get the fetal heart rate up by 5 beats per minute maybe, but the mums have to sit feeling really sick and yucky for about 6 weeks while the babies grow big enough to get out and give a suitable for size for a pacemaker. So only occasionally do we ever do that along the way. We have to remember maternal health. So as we say, the drugs we're using can affect the maternal ECGs, so we have to keep an eye on that along the way. We had a lady recently where we gave her the baby flecainide because the baby was hydropic when she first arrived. We immediately produced a Brugada pattern in mum's ECG, so one of the sudden death patterns. Mum had to have the tendency for it, but by giving flecainide, we effectively did a flecainide provocation test that the electrophysiologists do. So we put mum at risk of VT and VF by giving her drugs to treat the fetus. So we then had to switch to find a more suitable drug that was safe for mum. She didn't know she'd got that tendency. It's just brought out by our medication. And as I say, as the baby gets further on, the question is it better to leave it inside or is it better to deliver it and try and treat it outside? So that's fetal rhythms in a nutshell.
Thank you for that lovely talk. It is a very non-surgical, but it's very, very interesting and knowing what all you deal with and how, and then it can affect both mom and the child. Very interesting talk. Thank you for that. We are open for any questions.
Gordon Ramesh, yeah.
Hello.
Fantastic talk again. I mean, it's I've said it once before and I'll say it again. I think the series of lectures by the fetal cardiology team have been top notch and incredibly educational to the group and wider. I think as a topic, this is one of those that we really do. We're in the dark as surgeons about, and it's every session is an eye opener, and it's one of those I think even to a lot of the non-surgeons. I think your experience here is key because they're not conditions you see that frequently, and it's the volume of cases and the length of practice that you have gained that experience to deal with these conditions. So no, I think incredible, fantastic lecture, and you yourself as a resource to manage these is also an invaluable resource if that makes any sort of sense. So thanks again.
It does. You're quite right. I mean, Joyce, Ram, Caroline, and I bounce the ideas off each other, and sometimes it's a bit like everything in life, isn't it? It's a question of moral support for each other to sweat it out. Because sometimes, I mean, we do occasionally get in utero death, but on the whole, we don't. Usually, it's sitting it out, and most of the babies get there. And it is a question of just reassuring yourself that what you're doing is right. So we use each other as a resource all the time. Yes.
Gordon, thank you very much for agreeing to this nice, crisp, clear talk. I listened to you when I was registrar nearly 10 years ago, I think, and as you say, like the fetal tachycardia, the progress in the treatment is, I think it still goes by experience, from what you have seen, particularly things like, preventing heart block, like 2 to 3% in anti-Ro antibodies and or a recurrence heart block is still a nightmare in terms of what is the right way. I think the second baby prevention, as you say, the rheumatologist and obstetrician, then some studies they're coming out with 30% to 50% variable prevention on hydroxychloroquine, but that's the only difference I've seen in the last 5 years, apart from the conventional management what we had done. And again, picking up the right first-line antiarrhythmic for SVT is still under study. I think. I mean, we all go by experience and mom's safety, as you said rightly.
Yep. The rather sad thing is that in 1993, I got involved in when I was a cardiology fellow in Toronto, they had a big study and they were really into it. And we produced a paper from there. And what are we, nearly 30 years later, and nothing's really changed. But
It's lucky you're at Toronto at the time, then otherwise we might not know.
nice way to put it, yes. Okay, any more questions? If not, we'll call it a day and go back to work, or I'm going to go in the garden.
Excellent. Thanks again, Gordon.
Thank you so much.
Bye, everyone.
Thank you, Gordon.
Bye.
Bye-bye.
Yeah, sorry, Jamie Hamlin.